Greetings, everyone. This is Eric Laser, and welcome to Bright Spots in Healthcare, produced by Shared Purpose Connect. We bring leaders together to inform you, our audience, but also unearth bright spots, successes at health plans, hospitals, and other healthcare organizations around our nation. Our goal is to identify as many bright spots as possible so that you can determine if the ideas shared during this episode can be applied at your organization. We believe that this approach, this strategy of finding a bright spot and cloning it is the most effective way to improve healthcare in our lifetime. If you have not subscribed to Bright Spots in Healthcare, the podcast, stop what you're doing right now, go to your favorite podcast app, whatever that may be, type in Bright Spots in Healthcare, and please subscribe. Leave us a comment like this one from JIG in Brooklyn. Quote, best B2B healthcare podcast, incredible ideas shared by incredible guests. This is the best source to gain bright ideas. And then in parentheses, he writes bright spots from payers, providers, and other innovators, end quote. We're presently averaging a 4.8 on Apple, and the more ratings, the more subscriptions, the more comments, the more your peers can find this show and gain access to all the tremendous ideas and bright spots shared by our guests each and every episode, making healthcare better for all of us. All right, now that we've raised the bar, Dan, no pressure, let's get into it. Today's episode is going to be about innovations in mental health and overall navigation of the healthcare system. And we have kind of an unusual guest, at least for this show. We have the president of Sun Life Financial, the aforementioned Dan Fishbein. So welcome, Dan, to the show.
Thanks so much for having me today.
My pleasure. I'm going to tell our audience a little bit about you. Besides being a Celtics fan like me, Dan is an avid meteorology enthusiast. And something we didn't plan for, Dan, do you have a favorite New England meteorologist?
A favorite New England meteorologist? Well, he's since retired, but I have to say Harvey Leonard, formerly of Channel 7 in Boston, was my favorite. And that's probably because he was the first meteorologist to have me as one of his spotters.
Nice. You were a spotter too. All right, a little bit more about Dan. He earned his bachelor's degree from Boston University, same school that my mother went to, so we're practically related. Also, though, got his Doctor of Medicine from BU School of Medicine. He now serves as the Dean's Advisory Board at Boston University School of Medicine and is a member of both the Massachusetts Medical Society and Maine Medical Association. As president of Sun Life U.S., Dan has transformed the company into a leader in health-related benefits and services that connects the broader healthcare ecosystem to help people access the care and coverage they need most. He has been with Sun Life since 2014. A quick snippet of some of his accomplishments since he has taken over as president. Dan has overseen successful acquisitions that have given the company and its capabilities incredible growth and breadth, including the acquisition of DentaQuest in 2022, Pinnacle Care in 2021, Maxwell Health in 2018, and Assurant Employee Benefits in 2016. Since 2014, Sun Life U.S. has grown threefold to $8 billion in revenues, offering group benefits and services to more than 50 million of us in the United States through employers, partners, and government programs, and serves a block of in-force individual life insurance policy holders as well. So quite a resume, Dan. Super excited you're able to join us. I want to jump right into it and get right into mental health. When we were talking sort of before we press record, we both have a shared passion for this topic and how we need to get better in this country and all different aspects around this. So can you tell us a little bit more about Sun Life's commitment to supporting whole person care when it comes to mental health, and what are maybe some of the key initiatives or programs that you've launched around mental health, around whole person and holistic care, how they're working?
Yeah, that's a great question and a topic I love to talk about. I mean, first and foremost, we operate by the strong belief that mental health is health. There's really no difference between a mental health diagnosis and other diagnoses, and they should be treated the same. That's not always the case, but it's certainly what we're striving to do in our business. mental health conditions affect almost everybody, right? There isn't a person out there who either doesn't have some issue they've dealt with themselves or issues in their family. But the ways that mental health can affect people and families are very different. Sometimes it's a primary diagnosis. Very often it's a secondary diagnosis, and quite commonly a secondary diagnosis related to more of a physical diagnosis. We see that a lot in our business. So, for example, some of our benefits will provide help to somebody with a cancer diagnosis. Very often, somebody with a new cancer diagnosis is experiencing high levels of depression, anxiety, and stress, which can cause all sorts of mental and physical health issues. We recently launched a behavioral health program for our disability and critical illness members who've been diagnosed with cancer so that they can receive much needed mental health support while navigating their medical treatment journey. And some of the early results from this program have been pretty remarkable. 52% reduction in stress, 59% reduction in anxiety, 70% reduction in depression. And some of the direct member feedback we've gotten from the program's been, remarkably positive. It's a relatively new program, so we're looking forward to tracking more long-term results and sharing those insights with others as we get them.
So I want to ask you a couple of follow-ups about that program. So 52% reduction in stress, 59% reduction in anxiety, 62%, if I caught that right, reduction in depression. These are for folks who have comorbidities tied to both cancer and obviously a condition above the neck that comes with that. Have you guys been able to see any impact on overall results around the physical illness, overall reduction in cost of care tied to this program?
It's early, so we can't really show that yet, but we expect that to be the case. Obviously, people who are more healthy from a mental health perspective have a better chance, we believe, and there's a lot of studies out there that show that, of overall success.
Tell me a little bit about the program. Like, how does it work? How do you connect the different providers?
Yeah, so what we've done is, and we're working with partners on this, but first of all, the first goal is to identify people. So we work through people's employers to make sure that they're communicating about this program, to make sure that people know about it. But you know what? No matter how much you communicate in advance, people forget these things, right? They're faced with an array of benefits and programs. So more important is that the HR department is aware of this and says, wait a minute, we have somebody who's suffering right now. There's a program we can connect them to. Now, these programs are very tailored to people with these diagnoses. They connect people with providers both virtually and in some cases, if they prefer that, in person, for some really tailored counseling to deal with the impact of this kind of a diagnosis and the impact not just on them, but on their families. But we're increasingly using virtual connectivity as a way to get care to people in these situations.
Okay, so you're working with the benefits department at the large employer groups to identify individuals who may need this service and suggest it to them. Obviously, it's an opt-in. When they opt into the program, you find them the right mental health provider, whether that's in person or virtual. And how is there any connection that you have with the service that's providing and then the physical doctors that they're seeing for the condition?
Yep, and let me add, it's not just large employers; it's really employers of all sizes, and it's a program that everybody needs, regardless of the company they work for. Yes, there is connectivity. Of course, the patient has to agree to this, and they have to agree to the sharing of information under, all the various PHI requirements. But if that's something they want, we can certainly connect the providers who are providing the physical treatment and the mental health providers to share best practices. Absolutely.
And you mentioned the stress on the family, the caregivers. Is there anything about the program that touches them or enables them to see therapists?
Well, what we do is we provide educational support for the family. obviously a lot of what the family is going through has a huge impact. Now, this is probably a great time for me to explain, we're not a health insurer. We're one of those insurers that provides, one of the hundreds of insurers actually, although we're one of the largest, that provides lots of these other benefits. We don't love the term, but the so-called ancillary benefits that wrap around health insurance. So everybody in this circumstance has a health insurer and a health insurance benefit. And typically the family would be covered by that health insurance benefit for mental health counseling. And part of the overall program here is to refer people to the benefits and places where they can get help.
And so that's great. And that's a good transition. So the educational support, I'm assuming that you provide would be asynchronous and digital is my guess. Is that correct?
Yes, that's correct. Yep.
Okay, so let's talk about that. And how is Sun Life been leveraging technology and digital solutions to enhance the overall delivery of mental health and even caregiving support to any and all of your clients?
Yeah. Well, we believe in meeting people where they are. And of course, ever since COVID began, where they are is different. Look where I am today. I'm sitting in my home office. It's a Monday. That's where I typically am. So people are in very different places. And that includes a great deal more comfort in digital solutions than perhaps people had a few years ago. And that can be, flat digital solutions, information online. But as I mentioned earlier, virtual care has become a big part of the delivery system as well. And of course, with geographic issues, we have to be, very careful, very deliberate about that too, right? There's lots of ways now to deliver care to people, regardless of the geography they may be sitting in, as long as we can use virtual means. It also means we respect the fact that people are looking for different tools and different models, right? Some people, maybe in the past, the only solution was going in person to an office. That's clearly not what a lot of people prefer now. In fact, studies are showing that the majority of people prefer a telehealth solution for therapy these days. That's obviously a profound difference from where we were just a few years ago. So all of this is why our care solutions are virtual, they're holistic. The enhancements we've developed are designed to address availability, affordability is important, and appropriateness so that people can interact with their counselors or health coaches wherever they may be in the way that they want to engage. It's also a very important reason why we make data-backed decisions. A great example of that came from watching just the first 6 months of the behavioral health program for clients that I mentioned faced with a cancer diagnosis. Our data showed that more women were enrolling than men, a statistics that is backed by other research. But we also know there's a connection between mental health treatment and improved cancer survival, as we talked about, as it helps to be more invested in care during and after the treatments. So we made some modifications to the initial member outreach script to better resonate with all people. We understand that resilience and mental wellness is really important and is something people often neglect, which is the reason why we've developed an app called Health 360 to serve as our digital front door to health and wellness support, including additional resources for our stop-loss members, such as direct access to Health Navigator by Pinnacle Care, which is our health navigation program. And I know we'll get more into that later in the conversation, so I won't go into details here. But the app is all about making things accessible to people. One place where they can find things. Again, as I mentioned earlier, they don't think about it, even if we showed it to them on enrollment. But when something happens, they'll go to that app and then they're going to find lots of resources and easy access to those resources.
A couple of things I want to unpack. You said you were looking for different tools to create easy access. And when I say tools, I'm referencing specifically sort of things in and around whole person mental health. Could you illustrate a few of those tools and whether they're digital asynchronous, whether they're group, whether they're different various kinds of therapy programs?
So the app is, and certainly mental health is a big part of it, but there's a broad array of conditions that the app will help people with. In some of the products we have, like stop loss, we're encountering people who've generally had a sudden, unexpected, serious diagnosis. So there's both the mental health aspect of it, but there's also the physical aspect as well. So, for example, somebody who's being diagnosed with chronic kidney disease may be looking for support with the condition itself. So we have a program that provides that support and can really help people even with a lot of in-home care options. We also have a musculoskeletal option. We have in-home delivery of drugs that are typically only delivered through an IV in a medical facility. Specialty drugs, of course, becoming more and more common, but the delivery of that and the experience is a significant issue as well. So through the app, we're connecting people with a variety of resources that are specific to conditions they may have. And of course, back to the mental health issue, mental health is typically a comorbidity with almost any sudden serious diagnosis. So the app also connects them with a variety of resources, including the virtual care resources for getting mental health therapy that is specific to that situation.
So sticking with mental health for a second and talking about data-backed decisions that you referenced earlier, is there any enlightening pieces of information that you could share around beyond the fact that women are more likely to engage in mental health solutions? Is there anything about sort of different members at different stages in their journey and their healthcare journey, or different modalities, or even omni-channel kind of components of mental health services that you could share with us that maybe your data is showing you that we may be surprised about?
Yeah, I think, well, one that was clearly surprising was that women were engaging more than men. And that obviously led to us realizing we needed to update the communications, which we did. It's early, of course, on the data. But I think it comes back to the issue of virtual care again, right? Somebody gets a very serious physical diagnosis. Probably the last thing they're thinking about is, oh, I should get a therapist and start going in person to weekly therapy, right? They've got lots of very serious things to deal with, both the medical treatment itself as well as disruption to everyday life and family life. So probably, getting therapeutic support for a mental health comorbidity is very, very low on the list. So one of the things that we're seeing is that engagement is indeed much higher with the virtual solutions, because we're making that a very easily accessible aspect of care, which going through the traditional in-office approach, wouldn't be accessible to people, particularly from a time perspective when they're facing all the other issues associated with their diagnosis.
Okay, I'm going to ask you a question that we certainly didn't plan for, so maybe I'm putting you a little bit outside of your what you know day to day, but it's a clinical related question. Do you have any data on like what kind of, there's all kinds, we say therapy, you could have bachelor's level, master's level, psychologists or doctorate levels of therapy. Do you have any sense, I know you have all different modalities, right? CBT, DBT, exposure-based, we could go on. So do you have any sense of, your therapists, and your clients, what's been most effective? How are you doing with that therapeutic alliance? Do you have any sense of that from where you sit? Or is that sort of should we cut that out of the interview?
Well, we don't have data yet in the U.S. on that. And again, the care that we're facilitating is very episodic, right? Very specific to people with a specific diagnosis. This gets a little far afield, but in Canada, where we could talk for hours about this, where the system is so different. We are now a significant provider of therapy on a broad basis, as opposed to the unique circumstances that I'm just describing here. A part of Sun Life in Canada now is a business called Dialogue, whose business model is providing everyday kinds of therapy to every type of person through a virtual channel. Now, so they're accumulating tons of data. And one of the data points, of course, is that people prefer a virtual modality. As far as specific effectiveness by type of provider, I don't really have data on that. I can only give you an opinion. And, if we put aside things that involve significant medication and talk just about the range of things for which therapy is the treatment, it doesn't really matter the educational credentials of the therapist. What matters is their skill at therapy and the rapport that they have with the patients that they have. Sometimes, you could have somebody with a master's of social work who does fantastic, therapy. You could have somebody with 3 PhDs and an MD who just isn't, therapy just isn't their thing.
Yeah. So I was sharing with Dan, and some of you who know me know that I spent some time in Canada building a mental health program in my past life. And I would tell everyone listening that there are lots of bright spots with the disability insurance carriers in our neighbors to the north to look at. For different financial incentives, they're able to invest heavily in integrated collaborative mental health care. And yeah, Therapeutic Alliance is the #1 correlator to symptom reduction in therapy, at least from my experience in the program that I helped build in partnership with a carrier that will go, not mentioned, but I actually do have experience working with your colleagues up north too at Sun Life too, Dan. So anyway, just a quick commercial for Canada, if you will. But no, seriously, anyone listening, they should be looking at those big carriers up north and looking at for bright spots. Let's shift back down to the States, Dan, and talk about your collaborations with employers here and addressing mental health in the workplace, which is a big driver of change up in Canada. For sure, is mental health in the workplace. Bell Canada is one of the leading thought leaders in the country around that. Another bright spot to look at, folks. How are you guys working? How's Sun Life working with employers, and just elaborate on those relationships and the benefits you're bringing to employees?
Yeah, so the way we intersect with the employer around mental health, it happens in several different products. Certainly in disability, and I'll come back to that in a second. In disability benefits, sometimes the disabling condition is mental health. So when that's the case, we're obviously engaging in a very significant way, not so much with the employer, but really with the employee to help them deal with the condition so that they can get back to work and get back to their optimal level of functioning. For those employers that purchase what's known as stop-loss insurance, which is the risk coverage that self-insured employers purchase to protect against large claims, that's where what we've just been talking about comes into play. Somebody gets a serious physical diagnosis, and there's comorbidities very naturally coming from mental health, from the stress of the diagnosis, from the impact of the diagnosis. So those are the programs we've been talking about that we provide through employers to help people deal with that diagnosis. It's not as common a product, but we also have something called critical illness coverage, which is a supplemental voluntary benefit that many employers offer and that some employees enroll in. So they get some additional benefits if they or a family member has been diagnosed with a very serious illness. And some of these solutions come into play there as well. But putting a bow on the last couple of subjects, you mentioned, what's the bright spot that we can learn from our Canadian colleagues? And why are they able to do some of these more, intensive programs? And the difference in our system and their system is that in the U.S., disability benefits for a mental health primary diagnosis end after 2 years. That's basically the tradition in the U.S. In Canada, and it's the law, you cannot stop the disability benefits after 2 years or after any period of time just because it's a mental health diagnosis. So in Canada, they have decades of experience working with disability benefits that are long-term related to mental health diagnoses. We do not have that situation in the U.S. And our ability to observe that different system with our colleagues just to the north is the reason, or one of the reasons why, certainly not the only reason why, we're pretty much the only insurance company currently that is advocating for a change to the system. As I started out at the very beginning, mental health is health. And we believe that disability benefits should be the same for a mental health condition as they are for a physical condition.
Yeah, amen. I'm glad you said that, because I've been screaming about ever since my experience up there, like, hey, everyone thinks about Canada as socialized medicine. Well, we're much more socialized around mental health care in the U.S., at least as it relates to disability, with Social Security taking over and not really driving any incentive for innovation than we are in our neighbors up north, where all these companies are driving innovation again. Another place to look for bright spots. So thank you for saying that. Let's do this. I'm going to untie your bow, because now I want to put a bow on it. Okay. And I want you, I'm going to bring you down back to the greater Boston area from your home. I'm going to make you a professor at Harvard. If you want to be at BU, you could be at BU. We'll make it BU. Let's stay, okay. let's stay kind of loyal to the Terriers. And we're bringing in healthcare executives from around the country who are looking to rethink their mental health strategy and improve their various programs. A lot of people from health plans, not necessarily, we're not going to let your competitors come to the class. What would be like the high-level blueprint that you would introduce the course? Like, what are the 4 to 5 pillars that you're going to cover in this course so that your executive students are going to have a blueprint, a roadmap for success in building and innovating and building sort of novel mental health programs at their organization?
Okay. Yeah. First of all, thank you for recognizing the Terriers. Go be you. But there are 5 components that, I like to think about. But, admittedly, some of these assume that some of the bigger problems we have in the system are solved, or that there are ways to solve them. And we can come back to this, but access to care is an overarching problem right now, and it's getting worse. So the ability to access providers when people need them is something that kind of has to be thought about in the background of all of these issues. But, the first thing I would suggest to folks is start with prevention. Everything you and I have been talking about, and certainly that most people talks about something has already happened and now we intervene. But what if we could stop it from happening in the first place? So there's not nearly enough attention to helping people when, there's just the early seeds of something going on and digital tools can be a great, approach to that, to keep a condition from happening in the first place through education, through videos, through digital components, and even, ongoing therapy. We also must erase the stigma of mental health conditions. That's part of, all these conversations here. Even this idea, right, that some benefits only last for 2 years if they're mental health, and they last a lifetime if there's something else. Or if you have a disability that's driven by mental health, you get, basically dumped into a public system and ejected from the private system. There are so many aspects where there's a stigma around mental health. Now, as a society, we've made a lot of progress on that in the last 20 years, for sure. But there's still a ways to go, and it's ingrained into so many parts of our system. So anything being designed has to, take that into account and try to erase that stigma and equalize things. That leads to, a third very big component, understanding that mental health is health. It's not something separate. And it should be treated in the same way as any other health condition, with the same kinds of evidence-based care. Even in the medical profession, I've observed this myself, there are a lot of doctors who think of mental health as something else, as something different from a health condition. It's not. It's a health condition, and it must be looked at in the same way. Another one, clearly we've been talking about it, virtual solutions. Access is the issue I started with. Virtual solutions could be the solution to that. Of course, virtual is a conduit. It doesn't create providers unless and until we have AI therapists, which I'm not a fan of. But virtual solutions certainly bring people together in a far more efficient way. So even with the same number of providers, those providers can serve more people. But also it may encourage more providers to practice longer, practice part-time, practice in different ways. So that's a big part of the access equation. And then finally, maybe it goes without saying, is develop programs that are flexible and agile. Too often we look at things as a one size fits all. Part of what we've been talking about is lots of different solutions for different needs and different people. And that would be, a fifth key element, is make sure that solutions are flexible to meet people where they're at.
Okay, I'm going to summarize, and you let me know how I did here because I'm in your class. So start with prevention, digital tools, videos, articles for education. Number two, and I'm actually going to combine two things because you said erase stigma, and you also said mental health is health. So I actually wrote down, you need to erase the stigma in your benefit design as a health plan, looking to provide better access and better care, treat mental health as health, and make sure that the benefits around illnesses above the neck are the same as your physical. So I'm writing benefit design in there. Incidentally, we got to come up with a new word for behavioral and mental health, but let's take that offline for another short conversation. The third is virtual care, because it's going to potentially alleviate the stress on access, which is going to be an issue moving forward. You're a little bit anti-AI therapist. We should talk about that in another episode, because we're going to need to do something that's scalable. So we're going to have to figure that out as a community and as an industry. And number four, so that's three: prevention, benefit design, virtual care. Number four is developing flexible and agile programs. It may kind of touch that benefit design pillar. Could you, that last one, before we get off this question, Dan, can you provide an example of what you mean by that?
Sure. I mean, very often, historically, the traditional mental health benefits, whether we're talking in a health plan or maybe related to disability insurance, has been, if your condition is mild to moderate, you go for weekly therapy. If it's more severe, you may be seeing an MD who will use medication. But there's so many different things that, are available in addition to that. There's almost an infinite variety of therapies, types and styles of therapy, frequency of therapy, and now modality, or the communication methodology, in person versus a virtual. A lot of times benefits were designed to just, support the traditional and not support these non-traditional. So benefit design has to encompass all of that, can't, favor one over the other. And that means reimbursement mechanisms have to be flexed in order to support those. There's also a regulatory aspect. I don't know if, it's been in the news lately that a big controversy is developing. A big part of what's emerged in our system that's been a big advance over the past 4 years is the ability to do virtual therapy, including across state lines. That was a big challenge at the beginning of COVID. And now there's talk about eliminating that as we wind down all of the various COVID regulation and legislation. And there were some, changes made that facilitated somebody in one state treating somebody in another state. We need to keep that.
Don't get me started on that. So I have a daughter seeing a regular therapist during COVID when she was home in Massachusetts and virtually. And then she goes to school in New York, and now her therapist can't see her. That's the most outrageous, crazy, counterproductive thing I could think of. I'm so with you on that. If anyone's listening who has power in their state and federal legislators, we got to fix that. Got to fix it.
It was for a different type of diagnosis, but my wife recently was doing a virtual visit, and they told her that she had to drive to Massachusetts to do the virtual visit. She couldn't do the virtual visit from Maine. Now, asinine. How silly is that?
Asinine. All right, let's shift for a moment, because I want to get into navigation before, and a little bit of maybe future state before we close up here. But it does make me curious, as a physician executive running Sun Life financial, I want to get a little bit of inside, like who you are and what's your personal connection to healthcare and or mental health, and like sort of why are you in this space?
Well, not to get, too personal or give my biography, but I had a very different career journey, a pretty unusual career journey. I decided to go to medical school because of a strong interest in healthcare and improving people's health. And this is just me. Obviously, each person has a different approach. But as I went through medical school, I realized my ability to have impact was pretty small. First of all, I would be providing direct care to a small number of patients. But my view of being a physician is that the best physician is the one who doesn't innovate. Basically, what you're being trained to do is follow the accepted treatment principles. So obviously, you don't want a physician who's going to make it up as they go along. So as I went through the clinical parts of medical school, I realized that wasn't really me because I like to be more creative, and being a physician wasn't going to necessarily, facilitate my using my creative aspects. So I decided that what I really wanted to do was be in population health, where potentially designing and redesigning systems could take some creativity and could have potentially bigger impact. So I was very lucky. In the last year or so of medical school, I was mentored by a wonderful physician, Dr. Richard Egdahl, who was a real Renaissance man at Boston University. He was a world famous endocrine surgeon, a researcher. He was also a concert level pianist, and he was also the chancellor of the medical campus. But on top of that, he had created something called the Boston University Health Policy Institute, which was doing some of the early work on managed care. And I spent 3 months of my fourth year clerkships at the Health Policy Institute and kind of fell in love with this whole idea of health policy. And where I took that was into business, because a lot of the innovation that was happening, and that turned out to be true, was happening in the insurance world, actually. The whole world of managed care and all the innovations that came from that, for better or worse, was really happening inside the insurance industry. So I had a rather unusual first job after medical school, which was working at Mass Mutual in Springfield, Massachusetts, on the design of PPO networks and products. And then I kind of just, took it from there. That wasn't necessarily where I thought I would stay, but I have spent the last 39 years in the insurance industry since then.
Birthplace of basketball, Springfield, Massachusetts. So that's great and interesting. And it's Richard, Dr. Richard Egdahl. Did I get that right?
Yes, or Dick Egdahl. He passed away a few years ago, but he was a big influence.
It's a tremendous story. Could you, like, before we move on, like, what is like something that you believe related to healthcare, of course, that others just would think is absolutely crazy? Speaking of innovation, as an innovator, like what's something that you believe in that people would think is crazy?
Well, I think it probably goes back to one of the things, that I was just talking about. We need more innovation, not less innovation. And a lot of the way evidence-based design is developed in healthcare, it obviously is essential. It's exactly what we want to do. We want things that are tested, tried and true, will work repetitively. But it is to some degree a bit the opposite of innovation, right? So we need to facilitate as much creativity in healthcare as possible. And now there are some ways that we've done that recently. Very oddly, and this may be the kind of answer you were looking for, the Affordable Care Act, so-called Obamacare, unleashed a new generation of drug development. And when that program was being developed, nobody thought that that's what they were doing. Now, how did they do that? How did the Affordable Care Act do that? What the Affordable Care Act did, one of its many provisions, was it said insurance should protect you against the big things, not just the routine things. Of course, that's what insurance should be. So you shouldn't be like with a very serious illness and then end up, with a benefit cap of $1 million and end up with a $2 million bill because your care costs $3 million. So the Affordable Care Act eliminated all the caps on annual and lifetime maximum benefits, which were surprisingly common before the Affordable Care Act. So what did that do? That changed the conversation at every pharmaceutical and device manufacturer, but especially pharmaceutical company in the country and really in the world. Because previously, if a scientist had a great idea for a drug that could cure an illness, but would only be used 1,000 times a year, the conversation they had was, I'm going to develop this incredible drug. It's going to cost $500 million to do all the development and testing, and we're going to sell it to 1,000 people a year. So the pharmaceutical company would do the math and say, well, wait a minute, you couldn't possibly ever make that back because we can't sell it to enough people. And of course, benefits are capped at $1 million a year. So if you figured it out and you amortize the cost and it's going to cost $2 million per patient to do this, it's not going to work. So we can't fund your project, doctor. Sorry about that. With the Affordable Care Act, that dynamic changed. And now anything is possible. So we have drugs coming to market that are curing diseases like, hemophilia and cystic fibrosis, intractable genetic diseases that previously could never be addressed. Now, there's another side to that, which is the cost. The cost to society is pretty extraordinary, but the benefits to those people are extraordinary as well. Now, why are these drugs just coming to market now, even though the Affordable Care Act has been around for about a dozen years? Because that's how long it takes for drugs to be developed, get through the pipeline, get through approvals, testing, and so forth. And we are just seeing the first few drugs come out of that pipeline of what is actually an enormous inventory of new drugs behind them in that pipeline. But it's a great example of where people thought differently, facilitated new innovation, and now we're starting to see the benefits as well as the challenges from that dynamic.
Love that. I'm also going to give a shout out. There's another bill that got passed separate from the ACA called the Creating Hope Act that I have a personal connection to because my cousin helped get it passed. Shout out to my cousin Nancy Goodman. Just check that one out. That gets drugs to pediatrics and gives vouchers to research and developers. So I won't get into all that, but I love that idea and I love that call out. Super important. In fact, we need to figure out, Dan, when you were talking, struck me as we need to do a show on how to drive new innovations and best practices to the clinical community in shorter than 20 years, which is basically we got to do a whole thing on that, but I don't want to go down there now because I know we're running a little bit tight on time and I want to get this navigation, but I love that answer. No, let's talk a bit about navigation. Can you share, and let's talk about navigation and innovation, since that's a hot topic, right? So for us, can you share some innovative approaches that you've taken to make it easier for members to access care and then identify and reach the resources they need?
Sure. Well, one of the most exciting things that we've done, not to get, too commercial here, is 3 years ago, we acquired a company called Pinnacle Care Advisors. They're based in Baltimore. And what they do, we actually went looking for a business like them. And what they do through a pretty intense concierge-like approach with clinicians and healthcare navigators is they help people navigate our crazy healthcare system. And they focus in on people with serious illnesses, but they'll help anybody really with any situation, no matter how minor or major it may be. And they have some really interesting approaches they use. They've been, almost deliberately low-tech, people-intensive approaches. One of the most interesting and important things they do is they get people to the best possible provider. They'll often say, here's 3 providers we recommend for your condition. These are 3 of the best in the country. They may not even be in your area, but for your situation, we suggest travel may be worthwhile. But there's another part of this that people don't necessarily see that is absolutely critical, which is when you have a complex condition and you're referred to a new provider, the new provider does not know your story, and your story is typically very complicated. We find very often people in these situations come with a 300-page or longer medical record. It's not in the same electronic medical record system because typically they've gone to different specialists and have been referred around. So they end up with, first of all, even if the patient can assemble this, they end up with a pile of different documents, typically in paper, different medical record systems, lab tests from all over the place, and no decent summary of why the doctor is seeing this patient. My wife recently had a referral. I went with her. She wanted me to come with her. I'm sitting in the exam room, and you could literally hear the doctor in the hallway shuffling through her medical record. I timed it. He spent 25 seconds going through her medical record. He then walked in the room. He had no idea what her situation is, why he was seeing her, what her story was. He had budgeted a total of 15 minutes to see her, and it was most of that time was spent with him just trying to figure out why she was there. It was a useless visit. Now, what Pinnacle Care does is they say, okay, we've got to change this. The doctor has to have a summarized medical record. So they spend an average of 5 days of clinician time taking this mystery of these hundreds of pages and writing a story. They write a summarized medical record, and then they attach everything in an electronic file to it. Here's all the x-rays, the CT scans, the lab tests, et cetera. But here's this patient's story. So they have doctors, top clinicians all over the country, who love seeing their patients because instead of the shuffling in the hallway, they get this story, they read it the night before. Maybe it takes 15 or 20 minutes, but they know why they're seeing this patient and why they can help them. Now, would probably lead to a whole nother episode here, but that 5 days we think can be reduced to a few hours using AI. And we're already experimenting with that. So AI can ingest these medical records, draft the summary, and then the clinician just has to spend a few hours reviewing it, adding to it, making sure it's correct, instead of literally a week preparing that summary.
Yeah, clinical and just overall navigation in the healthcare system, sort of in my mind, the browser, it's the browser to the healthcare system, and we need just better browsers for sure. For all of us, it's going to say that first referral, right, is such an important component to the cascading effect of cost and quality. So really important. Glad to hear that you're doing some super cool stuff. How are you using, Dan, data and analytics to identify trends around these unmet needs and just care navigation in general?
Well, so we, in our stop loss business, we cover about 6 million people, but because of the way that business works and how every case just about goes out to bid every year, we have vast amounts of data on what is happening with high cost claims. We may have more of that data, frankly, than anybody else does. So we have the ability, and we cover more high cost claims than almost anybody else does. Whole other subject, but 63% of people in the country are not in an insurance plan at work. They're in a self-funded plan. And that's what stop loss does. It's a key part of self-funded plans. So we've got a very big set of data on high cost claims. So we know which are the categories that need the most attention. And that's why we've gone first to mental health, specialty drugs, kidney care, and musculoskeletal conditions and cancer care. And that's where the majority of high cost claims are and where we see the majority of impact can be made.
Mental health, specialty drugs, kidney, MSK, oncology.
Yes.
All right, let's talk a little bit about the future here. And I'm going to put you on the spot. So when you're thinking about the word successful, who is or an organization? What is a healthcare organization other than Sun Life or an affiliated Sun Life company that comes to mind, and maybe tell us a little bit why?
Well, it's easy for me because I actually had a personal experience there, but it's the Cleveland Clinic. Now, the Cleveland Clinic, and this goes back a good 20, 25 years, they redefined themselves from the patient's perspective, which no big healthcare delivery organization had done at scale prior to them. And they did an effort where everything was looked at through the patient's eyes, and they involved every employee, whether it was somebody cooking in the kitchen or the head of a surgical department who was a world famous physician. They all went through this program mixed up together and redefined everything they did according to patient journeys. One of the things they did was they said, we've been organized, and all of healthcare has been organized around physicians. You know, the departments, the clinical departments are basically what the physicians are interested in, but they have nothing to do with a patient condition. So they restructured the entire hospitals and really their whole system around patient conditions as opposed to medical specialties. So, you know, instead of having a cardiology department and a cardiothoracic surgery department and a CT, you know, a radiology department that did cardiac, they have a cardiac center. They were one of the first hospitals to do that and to redesign in that way. And then they put every type of clinician and ancillary provider needed into that, you know, into that institute, basically, a single building, a single organization. But it went well beyond that. They figured out how everything looked through the patient's perspective. Every employee in the place actually pretended they were a patient and then gave feedback and went, you know, including even, you know, wearing Johnnies and things like that. They went through the whole process as if they were a patient and said, wait a minute, this doesn't work. That doesn't work. So when I was there, you could see and feel. By the way, I had the chance to be there both as a business person once and as a patient. And you could see and feel the way that worked. Every single person identified as a clinician, as a caregiver. Every single person tried to help you, and every single person was transparent and shared anything, including at one point, my wife was in the elevator and was chatting with another family member about how bad the food was. And a third person in the elevator said, you're absolutely right. It turned out she was the director of food service.
Yeah.
So that's the way they viewed things. The other thing, in that, you know, it creates an overall level of excellence. We met multiple staff people. I'll never forget one nurse I was talking to one day in my room. We just got to chatting, and she was in her 20s. She had moved to Cleveland to work at the Cleveland Clinic. She had no family or other connections to Cleveland. So I asked her, so why did you come here? She said, oh, it's simple. I wanted to be part of the best team.
Love it. A players attract A players. Great story. Love that. Let's look ahead here, and you can put your Sun Life hat back on. Thank you for sharing that. What are some key areas or innovations that Sun Life is pursuing to further enhance just whole person care as it relates to both mental health and care navigation?
Yeah, so I think what we've been going through, and you mentioned it at the very beginning. You know, we started out, if you go back about 10 years ago. We were, one of those hundreds of so-called ancillary insurance companies. There's the old joke out there, right? There's the big insurance companies, and then there's the companies like us, which give you fries, right? You know, the big insurance company is the hamburger. We sell fries. Do you want fries with that? But we've tried to reinvent that completely and say, wait a minute, we're not, extra independent standalone things. Everything we do is related one way or another to that healthcare benefit. So we have to think of all the things we do as fully integrated into healthcare and as providing an important part of healthcare delivery to the 50 million members that we serve. So we've re-engineered the way we think. We're not, providing a standalone benefit. We're providing something that is an integrated part of healthcare benefits and healthcare delivery. And every person at Sun Life U.S. thinks that way now, and they think of themselves as being in the healthcare world, not as being in the insurance world or being in the, ancillary world or so forth. So that's the high level. So how does that manifest itself? It manifests itself into interconnectivity with the rest of the system. Our system of healthcare in the U.S. is massive. Being in a Canadian-owned company, I point out to people all the time, they're probably tired of hearing this, that the U.S. healthcare ecosystem is at $4 trillion, is twice the size of the entire Canadian economy. So it is big, it's massive, and it's complicated. It involves hundreds and hundreds of different entities and dozens of types of entities, and they don't work well together. So what we've focused on is working well with the rest of that system. So we have over 100 partnerships, major partnerships with other organizations. And we've put most of our IT investment into connectivity with other parts of the system, using tools like APIs and others. We're one of the leading users of that, so that data moves around smoothly and easily. People don't have to do things 2, 3, and 4 times. They view their work with us as part of a bigger ecosystem.
So in many ways, and maybe I'm biased because I just heard the Cleveland Clinic anecdote, you're almost taking a page from the Cleveland Clinic sort of strategy of turning into a patient-centric organization, and you're now becoming a healthcare integration or interconnectivity with the rest of healthcare kind of view on everything you guys are doing.
Yeah, and in fact, we do lots of work around member and patient journeys. So our people actually spend time looking at things. How does this work? Not as an episodic piece of something, but what is, to take a more mundane example, but it's huge. When an employer does their enrollment process with us and the whole onboarding process, what does that look like to the members, the employees of the company, and to the people in the HR department who are trying to facilitate this and put this together? In the past, we looked at it as a transaction. How do we set up billing? But now we look at it as a journey. They've made the decision to come to us. Maybe they made that decision on October 1st, and on January 1st, the benefit starts. During those 3 months, what's the entire journey? And how do we make that happen on time, in a way that's smooth for everybody involved, and in a way that where one step leads to the next? We didn't used to do that. And most of our industry didn't used to do that, and probably still doesn't do that. But we look at the journey rather than the transaction.
I like that. Look at the journey, not the transaction. All right, this was great, Dan. I appreciate you spending so much time with me. Where can people find you? Where can they get more stories about Sun Life? Social media, website, anywhere we could point people?
Well, sure. And I'm active personally on LinkedIn, so please feel free to follow me there. You can find, if you go to sunlife.com and click on the U.S. pages, you can find tons of information on Sun Life U.S. Our newsroom has a lot of information, including our recent public statement that we made on mental health parity. You can follow Sun Life on LinkedIn, Sun Life U.S. on Facebook, Instagram, and TikTok, and we have a YouTube channel.
Nice, as we do, where you can see a video of this very episode. Nice. I want to thank everyone who's listening for letting us slip into your incredibly busy calendar, whether you're on a walk in the morning, on a workout in the afternoon, in the middle of your workday, in the car, at the airport. I know there are lots of different things you need to be doing, and we do not take the time you spend with us for granted. So thank you for tuning in. Thank you. I hope you gained a lot of value here. We hope you use the bright spots and ideas shared today to inspire your thinking and enhance your organization's current approach to improving healthcare for all of us. Friendly reminder to subscribe, rate, and leave a comment to Bright Spots in Healthcare. This will really help us grow the show and reach more folks and help make healthcare better for all of us. We produce this show for you. Remember, this is your Bright Spots in Healthcare podcast. Take care, everyone.